All right, welcome. Welcome, everybody. Thank you for being here today. For those of you who brave the potential for a rainstorm, thank you very much. Everybody get a lunch ticket? Who wanted one today? Now, if you don't have one, they're available outside. I think we made arrangements to serve up to 350 box lunches, and of course, we were trying to entice you to come today to hear about Best Care. We're going to spend some time with that. That's obviously very important to us. It's the most important thing on the institutional agenda for the next year, couple of years, 3 years. And we're going to talk more about why that is the case and also try to convince you this is something for everyone. Being the best is part of our vision as an institution. Remember the vision statement? We work together to work wonders, to help define the future of healthcare and be the best in all our endeavors. People come here to be the best. Now, I'll bet if I ask this audience, particularly today, how many of you didn't come here to be the best and won't get any hands? But I really believe that's pretty reflective of the case for most of the people that work at UTMB. We are here because we want to help make a difference. We want to be the best, and for many of us, it's important to have that recognized, that we're working to be the best. And not only are we individually going to be the best, we're going to be the best together as an institution. We're better as a team than as a group of individuals. So we're going to talk more about that. We're going to focus on that. Hopefully I believe we'll have time to address some questions. I know we've had a few that have come through the Employee Advisory Council. That will be very good if you all don't have questions on your own. But before we get to that, I want to open with Way to Go Awards. You know, we started this practice a number of months ago, and I've been very pleased because now pretty regularly getting messages from people around the institution recognizing our fellow employees for great work, for going the extra mile, for stepping up, for playing a leadership role, for taking extra special pride and having a sense of accomplishment relative to what they do for the institution. So today I want to recognize 4 members of our environmental services staff. They're colleagues, many of you know, they actually are contracted, but they're part of our team. They work with us. They are colleagues in terms of what we do to provide a safe and a healthy and a clean environment for all of us, for our patients, for our students, and the visitors to our campus. So I have 4 that I'd like to recognize today. I'm going to read their names and tell you a little bit about what they've done and then ask them to come up for a picture. So the first is Bessie Martinez. She is from Women's Unit 9D, and from April 1st to August 17th, the scores for her unit in terms of cleanliness, environmental service metrics, and the like were 90th percentile and 94th percentile in the 2 major databases that we work. For Raina Martinez, Women's Unit 11D, same time frame, 88th and 94th percentiles. And again, these are top among the units. Miranda Batista, who's Women's Unit 11A, 97th and 98th percentiles. Also, Elmira Oriano, who works in our Galveston National Lab. Now imagine what it is to take care of the Galveston National Lab with the activity. And Dr. LeDuc actually sent me a note and talked about the incredible contributions Ms. Oriana has made to keeping that facility clean and going the extra mile. So I wanted you all to join with me in recognizing them today. this. Why don't you step on up and get a picture? Thank you all for that. All right, I also want to recognize, although I don't have a blue shirt for them, four of our marvelous faculty members. You know, UTMB, from my perspective, greatest legacy over the past 125 years has been the education of health scientists and health professionals who have very ably served our state, served our nation, and particularly around the world. And that tradition continues. We're regularly recognized for the outstanding work of our faculty. And the Regents, a few years ago, decided that it's a great idea to recognize outstanding faculty with great accomplishment from all across the system. So the nomination process starts with the Council of Deans and the Academy of Master Teachers. Actually can come from any other faculty member, anybody here. Portfolio of educational experiences and teaching is put together and submitted for review by an expert panel at the system level, and then that panel makes recommendations to the Regents relative to the awards. So this year we had four of our really wonderful faculty members. Those of you in the academic enterprise know these four very well. They were recognized on August 24th. There was a very nice dinner and recognition ceremony at the Regents meeting. They received a beautiful plaque. There also is a $25,000 award. They can either go to the individual or go to their program or some combination. So it's significant in terms of its financial recognition. And of course, we're so proud that these four have been recognized for their contributions to education, not only here at UTMB, but across the UT system and in service to our state. So please join me in congratulating Dr. Gurral, Dr. Helmuth, Dr. Hill, and Dr. Carney. Now, another word about something that's coming up. We're a very generous organization, and I think that relates to the sort of people we attract. In fact, we want to be our best, we want to give back, we want to make a difference. We have a contribution opportunity associated with the state employee charitable campaign that always starts and runs through the mid-fall. This year, the dates are a little bit earlier than they were last year, but roughly the same time frame. Formally beginning October 7th and lasting through November 17th. Our goal as an institution is to contribute in total $525,000. We actually were right around that last year, so I know we can make that goal. And we can contribute through cash contributions, check, payroll deduction is an option either over the course of months or at one time. A lot of ways to do this. And it's a way for us to contribute back to the communities we serve. For those of you who aren't familiar with the program, there's a roster of charitable service organizations, and we can select from among those and distribute our contributions as we see fit among those organizations. And so certainly in all the communities we serve, there are opportunities to give back to local service organizations. One story that Dr. David Marshall told me about, we have the UTMB Good Neighbors program, which is one of the listed charity opportunities. And this particular program allows us to reach out to some of our neediest patients and help them with some of their social needs. And those of us who deliver health care know that oftentimes it's the social determinants of health that have the major impact in terms of what makes for long-term health, as opposed to the actual health issues. That people can't get food, can't get to food, they have food insecurity. If they can't get their medications, if they don't have basic living resources, it's pretty hard for them to be healthy. So the particular example, David, may I repeat that example? Not the patient's name, but we had a lady
who was a very frequent visitor to our ER. She was admitted on a number of occasions. She had a lot of issues that were associated with sensitivity to the heat, which then caused exacerbation of her health issues, and she showed up here. So using the proceeds from the Good Neighbor program, we were able, or the organization was able to get an air conditioner for her, a small portable unit, and markedly reduced her visits here. So little simple things like that are done through these programs. So I encourage you to consider contributing if at all possible, and even a small amount of dollars can go a long way to making a difference. So thank you for your consideration of this. More details will be coming as we get closer to the start of the program. Now, some really good news. Some of you are aware of this. We had a really great financial performance for FY16. We had projected a $12.2 million loss based on our best estimates of what was going to happen, patient flow and the like. And we were actually pretty close relative to patient flows and volumes, but there were some extraordinary efforts on the expense side by our people across the institution. We also had some other factors that allowed us to record some revenue we didn't know we were going to get to record. So it looks like we're going to be around that $10 to $15 million mark. Right now it's sitting at 13.4 to the positive. So that's really incredible. I just want to join the other three up on stage here, Dr. Jacobs, Ms. Sagro, and Sollenberger, and thanking all of you, people all across UTMB, for helping us have such great performance. What do we do with the money? Well, it goes back into education, research, and patient care, and making a difference. That's why we care. Why the old thing about the sisters at one of the charitable institutions, no margin, no mission? That's really true. So having good financial performance is important to us. That's why we work hard to achieve it. It's not just about the money. It's about enhancing our ability to make a difference. We certainly want to recognize our employees for the great work in the past fiscal year. So I'm happy to announce that Dr. Jacobs, Ms. Saber, and Ms. Sollenberger have recommended that we provide a team award this year in the amount of $625. That's an increase over the last few years, and so more details about that. But we plan to do that for all eligible employees. That should occur about the November paycheck about the time. Okay? Congratulations. Now getting to best here, what I'd like to do is turn this over to Ms. Sollenberger, because she's going to describe how we are engaging the information that's used to describe how good we are. Now, that's really important. I'm a doctor. I don't see patients that often anymore. I can tell you what we doctors typically do when we're confronted with data about our performance. That's not my data. Doesn't describe me. No, sir, that's not right. I'm not even looking at it. And in the old days, we could stomp our feet, turn red, scream, deny it, walk off, and oftentimes get away with it. Guess what? Times, they are changing. Because now it's not just the institution. It's the U.S. government. It's all the organizations that we belong to. It's the people who pay us. And they're looking across every provider's performance and providing feedback about how we're doing. And then they're rolling that up to assess where we stand relative to our colleagues all across the country. Well, why is that important? Well, we all came here to be the best, right? We want to be at the top, and we know being the best means that we're more likely to make a difference. But the other thing that it means for us is more and more this data, this information is being used to determine which patients come here, if they're allowed to come here, if they're allowed to receive certain services here. Of course, what we get paid for delivering services. So if our education and research and patient care programs are going to continue, they're going to survive and continue to thrive, we can't say that data doesn't apply to me. We have to engage it. We have to understand it. We have to, in some cases, change the way we work, particularly together, so that the data truly reflects our efforts to be the best. So let me turn it over to Ms. Sollenberger. She's going to talk more about this, how we're engaging the data, what the measures are, what's happening right now in terms of how we work with our efforts to work together so that the data really reflects who we are, how good we are, and how good we want to be. Ms. Sollenberger.
How's everybody today? Good? Yeah. Pretty much. Got to be a pretty good day, I guess. I get the pleasure of talking about best care, and I really like doing it because we have it happening all over the organization. And I've had people say to me, well, our mortality score isn't very good. Is that a problem? And the answer is maybe. It depends on, and you're going to see, some of the differences in how we calculate mortality or how we calculate any of the numbers. So what I wanted to do, and I hope this succeeds, is to try to describe best care according to the measures that Dr. Callender talked about and explain those hopefully in a way that everybody understands what it is we're trying to do. Because I think some of the things, well, what does it mean to be efficient? You know, well, it could mean a lot of things, but in this data, it means certain things that we will talk about. I mentioned before that Chancellor McRaven has presented to the Board of Regents his 8 quantum leaps that he wants to make in the UT system. And if you'll notice, if you go down the way, about 5 bullets down, it says the UT Healthcare Enterprise. Well, he put out a challenge to the presidents some time ago, probably in the spring, that he wanted to make sure that every one of the UT system hospitals and health components were in the top 20 of what's called the Vizient benchmarking data. And so, how many of you know what Vizient is? Let's just start there. Some do, some don't. We belong to an organization, Vizient, used to be University Health Consortium, UHC, and they basically collect data that we send them, along with the data from about just a little over 100 other academic organizations. We like the data because those academic organizations, in many cases, look a lot like we do. They teach, they do research, they take care of vulnerable populations, and they do it well, and many times with some of the socioeconomic conditions that Dr. Callender described. So when the Chancellor wanted us to be the best, really, in healthcare, we started looking at how could we move the needle on our performance with this Vizient data. And so that we could be in this top 20, so out of the little over 100, we want to be somewhere between 1 and 20. And our target is really working hard to get that to happen by the end of August of next year, based on the data which would be reported then a little bit later in the fall. It's a lofty goal. It will require intense focus, which is why we're talking to you about this. It will require intense focus, and it will require everybody to participate. So the Chancellor is very serious about making the UT system the best, and within it, the UT health components the best. So some people say, well, what is healthcare quality? Is it about, to get it, do we have to work harder this year? Do we have to find out really who's to blame for those outcomes and do something about that person? No, it doesn't mean that. It means we're going to deliver the right care at the right time in the right way for the right person so that that person has the best possible results. We're calling that every patient, every time, without fail, we do the same thing. So it's about getting more standardized in our approach, more focused in what we're doing, and working together optimally as a team. When we look at the data, some of the areas where we fall down are in teams. As nurses, we work together well on our units and in our clinics. As doctors, we work well going around with the residents and our students talking about the patient. But we haven't maybe integrated all of that as well as we could so that all the people who touch that patient have the same information and understand what the plan is for the patient. And so rounds might look a little different. How we talk to each other and communicate may be different, but we want to be optimal or highest performing in the communication, and that's where we can do a better job. So how are we doing in this quantum leap? Where are we today if we have to be in the top 20? Some of you have seen this from Mondays in March. We're solidly stuck in the middle. And we want to improve that. So we are basically 59th out of 102 organizations. And when we're looking at this, that makes us, according to the Vizient data, they assign health system stars, from 1 being the worst to 5 being the best, and we're 3 stars. How many of you feel really good about that? No, because it's like Dr. Callender said, we want to be in a 5-star hospital or clinic, don't we? As a patient, as an employee, we want that to turn to 5 stars. And if we get to the top 20, and when we get to it, we will have 5 stars there. That's what we want to tell our patients. That's what we want to tell our families. You are coming to the best possible place for the care that your loved one or you needs to receive. We're also looking at 6 areas where we are focused. 4 where we need improvement, and 2 that we need to maintain. So I'm going to talk about mortality, efficiency, effectiveness, and safety as areas where we can improve to get into that top 20 and achieve best care. But I also want to talk about the 2 where we're doing really well, which are patient-centeredness and equity, which I think is extremely important as we move forward. So the mortality rate, what is it? Simply the number of people that died in the hospital. And that doesn't mean we did a bad job. I mean, we're trying to do the best we can, have the best possible outcome for that patient in the condition to which they present to us. So it's going to compare, based on that patient's illness, how many expected deaths did we have, and then how many actually happened, which are called observed. So when you hear this, you might hear the expected, the observed mortality. And so it's actually a ratio. So you have, remember, division, and I don't know, back then I think in 6th grade when they taught us, they probably teach it in kindergarten now, but it's the actual deaths divided by the expected deaths, and that gives you this mortality index. Well, we're 60th out of 102, where focusing on this, first is the best. So we want to be first, we want to be in that top 20. So we're looking at 2 things. What could we do in the hospital in observing patients and having an intervention that would prevent a death? How can we prevent someone from dying in the hospital? And then sometimes, and we found this as we peel back the data, we are doing a good job, but how we dictated it, and then how we, or still not dictating, or fill out the electronic record, and then how we code it is working against us. It's not really, we haven't really described how sick that patient really is. And so when they pass away, we wouldn't, based on our documentation, expect it, but when you get into the details of that patient's condition, we probably would have. So we are really looking at each death and trying to say, which ones could we have prevented? And of those, how would we have done care differently? How would we have recognized the decline sooner so that we could have had an impact? And then we're also focused a lot on how do we improve our documentation. So talking to our residents, talking to our physicians, and trying to do a better job of educating so that when they fill out the record, it's really being complete and accurate in how ill that patient is. So does that help a little bit about what mortality means and what our focus is? I'm seeing some nodding heads, so I hope so. But that's really where we can make some improvement. Effectiveness, we're about at the same place, 59 out of 102. First is the best. And our overall score is 63.4%. So what is effectiveness? Well, it's producing the desired outcome and experience of care. And we're focused on following best practices known and achieving our goals by following evidence-based national hospital quality measures. One of these is core measures. So what's a core measure? Well, one example, if someone is in a clinic and they have symptoms of chest pain, how quickly from that time till we get them an EKG to see if there's a problem. Or Annette knows this and so does Christine Wade, and anyone from the emergency room, someone coming in with chest pain, how quickly we get them that aspirin so that we can make sure that we have the best possible way of improving or making sure the patient gets the best care that they need. So we're really focusing on how do we improve in the measures, and there are a whole bunch. We're not looking at every one because some of them we're doing really well in. But it's the ones where we show we can make improvement, that we're having laser-like focus and working with groups to try to reduce, trying to improve our effectiveness and improve our score. The other thing we're looking at is preventable 30-day readmissions. Why is that important? Well, in today's world, it's called value-based purchasing, people are getting penalized if a patient leaves the hospital and within 30 days, for any reason, gets readmitted. Now, that doesn't mean we're not going to admit someone who needs admitted, regardless if they were here yesterday or 59 days ago. But what we want to do is when we discharge them, are they getting a clinic appointment in a timely way to be followed up on? Do they have the resources to get the prescriptions that they need and be able to stay out of the hospital? We have a group called the Community Health Program, and we have case managers and healthcare workers that will go into the home and check, do they have the medicine? If you have congestive heart failure, are you weighing yourself every day? Talking about, have you gotten your appointment scheduled and how are you going to get there? So we need to do more work in the outpatient side to try to keep the patient from coming back, because we know if we don't have that intervention, many times people, especially people who have a difficult time getting transportation, getting pharmacy, their drugs at the pharmacy, all those things will mount up and cause them to return to the emergency room. So it's, are we getting the desired outcome and experience of care? And we're looking at nationally known quality measures, and we're looking at 30-day preventable readmission. So again, this has a focus to what we're doing, and then we're looking at those areas where we have the best opportunity to improve. Efficiency, because sometimes people say, I don't really understand the difference between effectiveness, producing the desired outcome, and efficiency, which is really doing the right thing at the right time in the right setting. So it's all about using our resources wisely. Could we do that MRI as an outpatient and reduce the length of stay by a day so that the patient can get their test, but in a less expensive setting? That would be one example where we're trying to do that. So we're focused on overuse? Are we ordering too many tests, too many drugs, too many procedures? And so we have groups of clinicians working on this, people who really understand patient care. Can we prevent hospitalization by managing the patient better in a clinic setting? Could we say, come to the clinic, we'll see you at the end of the day, or we'll see you, just come to the clinic, we'll work you in. It may take a little while, but we'll work you in, as opposed to go to the emergency room. So it's really trying to figure out where's the best place for that patient, because then we can work at trying to make sure they get that care, but in the right setting, which will affect not only the quality but the cost, because we don't want to go to the hospital unless we really have to. It's not the best place in the world to have to be. Length of stay is the other thing that will help with efficiency, and that's one area where we're doing tons and tons of work. And we've again done it by where do we have the biggest opportunity, so that we're focusing on those areas first, and I would imagine as we go through this, we'll get more and more refinement and more areas included. Safety, this is preventing events and complications we know how to prevent, so we're reducing harm or harm that could have been avoided. So, are we turning the patient frequently enough, and are they in the right kind of bed so that they don't get severe pressure ulcers? Are we recognizing the signs of postoperative sepsis as quickly as we could? So sepsis, you probably heard that, but it's a severe bloodstream infection, and Dr. Sharma told me, and it's where an organ system is affected. It's not sepsis unless that organ system is affected. So how do we document so it's very clear that this patient really does have the beginning stages or does have sepsis? Postoperative hemorrhage or hematoma. This is where Dr. Sade and Dr. Hankins did a lot of really good work, because they saw in their department they had room to improve. And they did such good work that because of it, UTMB will not be penalized. The $2.5 million it has been penalized in the past for not performing well, it was amazing work. They reduced this to 0. So it can be done, and they did it in a matter of 6 months about. So when people say to me, can you really do this in a year? I have to turn to Dr. Hankins and Dr. Sade and say, they've shown that you can when you identify the issue, you really focus on doing it right and well, and you look at the data and you continue to make improvement. And Dr. Sade has said they're going to continue to review these so that there isn't slippage. But the single biggest barrier for the patient remaining safe in the hospital is teamwork, communication among the members of the team. And that's why I said early on, this is really about working together in the best possible way, knowing what the plan is so that everyone who cares for the patient, knowing what the plan is so they have the best possible outcome. Now, the two stories that are really, I think, important to tell that we do well, because I have people say, well, Donna, all you think about is money, right? No, that's not. What I think about is, are patients getting what they need in the hospital, and are they getting out at the time they should be getting out with the best possible outcome? You know that we take care of all kinds of patients. We take care of patients on Medicaid, we take care of unsponsored, we take care of prisoners, we take care of very vulnerable populations. And what this metric says is, despite that, is everyone who comes in with that condition receiving the same care? And so we ranked 100 out of 100, or 1 out of 102, where 1 is the best. We want to maintain that. That's something we should be very, very proud of. So I wanted to emphasize that because I'm not sure that we had as much. The other great story we've had is on patient satisfaction. And so that measure is patient-centered care, and we measure our satisfaction by the Hospital Consumer Assessment of Healthcare Providers and Systems Survey, which is why we call it HCAHPS. I don't think I could rattle that off every time. But it focuses on how well do the doctors and nurses communicate with me and each other. How do they respond to my concerns? Are the staff addressing my emotional needs? How well is my pain controlled? Am I clear on what I need to do when you discharge me from this hospital? Do I understand how to use all those medications that you're giving me? Some of them, on our transplant patients, have bags that they would be rummaging through to basically get all the things they need. Does someone know in my family, or do I know when I need to take all of those and what they are, what happens if I don't? Is my environment good? Is it clean? We found out we had some great awards on way to go in terms of the cleanliness of the environment. But also it looks at quietness, so thinking about kind of keeping the noise down, because that's a measure. And then how friendly are we, and how well do we work with visitors? So I want to use an example that I think is very real. We could do every single thing right, 100%, and the patient and the family can walk out the front door of John Seeley, or be wheeled out of John Seeley or Jenny, with a fabulous experience. But what happens if they try to get their car out and they have a hard time with parking for whatever reason? So it's not to pick on parking, because you guys are doing, I think, a good job. No, it's not that, but it's just to show you how it just takes one thing to ruin the experience. A patient comes in and we don't look up and say, "May I help you?" But I've still got my head down looking at my computer. Those are the differences between starting a good experience or starting out on the wrong foot. So I tried to go through and think of the top 10 ways everybody contributes to best care, and that's regardless of where you work at UTMB. First of all, we have to commit to it. It can't be, it's just another one of their programs. It's not a program. It's really what we want to do. It's embedded in our mission, it's embedded in our vision, and it's embedded in our values. We want to work effectively in teams. We heard earlier how that's actually hampering us if everybody on the team doesn't know what their role is and what's expected. We want to demonstrate leadership. That's not just for me or for my colleagues up here on the stage, it's for all of us. Everybody in this organization has a leadership role. If you see something that needs to be picked up off the floor, pick it up and then use your hand sanitizer. If you see a ceiling tile that needs replaced, call it in so that someone in facilities is aware of it and can fix it. So you have a leadership role. If you see something that you think may not be the best thing for that patient and you're concerned about it, speak up. People say, well, if I do that, I get my head bitten off. If that happens, we need to know about that, because we all need to be ready to be focused on the patient and doing the right thing. I could have intended to do the right thing, but start to do the wrong thing. I want someone to tell me that. I don't want anything to happen to the patient. So that means we're going to have to maintain our focus. We're going to have to create and support a blameless environment. It isn't, when the phone system went down at Angleton last week, I didn't call up Todd and go, I can't believe that phone system, what are you doing? But what I did ask is, what are we doing so that we can create a better system? And Todd told me we're creating the redundancy so that soon that won't be an issue. If it goes down one way, there's another route for the calls to come in. So it's working with each other to come up with solutions that help to solve the problem. Collect and use accurate real-time data, which we are doing, as you saw as we walked through this. We want to hardwire for success, so that means working on the workflows within Epic. following standard procedures and the order sets that Dr. Rogers and his team work on with physicians and other clinical providers. We want to use our resources wisely so that we have them to maybe even extend the care for more people. We want to speak up about problems, fears, conflicts, and misunderstandings and be supportive in helping each other find solutions. I could spend all day pointing fingers at, well, they didn't do their job, I did mine. That shouldn't make me feel good at all. What should make me feel good is saying, ooh, I see this problem. Let me call up Josanne and say, how do you think we can fix this? This is what I'm thinking. Do you have another approach? And then the easiest one is always warmly greet and assist patients and visitors and each other. These are hard jobs. I appreciate everything everybody's doing, whether you're in patient care, the academic enterprise, or institutional support, or the president's office. We're all in this together because we have people who are depending on the good care that we can give them. So we want to be the best together. And we did just a little video that we want to show you of some of your colleagues telling about what best care means to them.
Hi, I'm Felicia Royal with Environmental Services. Best care to me means that we go above and beyond with visitors or patients, meaning that we can take our patient or our visitor to exactly where they need to go. Not just point to where they need to go, but actually walk them to the office, to the place that they're needing.
Hi, my name is Kurt Dixon, and best care to me is consistent care every time with every patient.
My name is Ariel Thomas, and best care to me is making sure the patient rooms are neat and clean and sanitized.
My name is Janice Layer, and I affect best care by making sure our patients are taken care of during their appointments and that they leave knowing that we care about them and their health.
Well, my name is Brian Moses, and best care means delivering 5-star service 24 hours a day, 7 days a week.
I'm Tilly Clark, and I work for the special use facilities. And I support Best Care by creating a positive environment for our community, both internal and external to UTMB.
I'm Matt White from Employee Health, and I support Best Care by taking care of our staff so they can take care of our patients.
Hi, I'm Ruth Finkelstein, and I support Best Care at UTMB through my interaction with the UTMB Professionalism Committee. Professionalism has 3 main components: respect, compassion, and integrity. This is part of our mission.
My name is Leanne LeBlanc, and I'm Kajal Campos, and we work in employee health, and we keep our employees healthy by giving them flu vaccines during the flu season.
My name is Demetria Burgess, and best care for the patients is top quality.
My name is Tommy Fields Jr. I am the customer service rep for the Department of Radiology. I affect best care by making sure that our patients are done in a professional manner, but what's most important to me, that they are pleased with our service. Being a good patient advocate is very, very important for our institution. Communication, dedication, and motivation. Best care.
For the EVPs to join me up here, obviously, best care is for us, best care is for everybody. Being the best is for everybody in UTMB. Now, we're focused on the clinical metrics and outcomes right now because the Chancellor has challenged us to be. What's coming next? Similar focus on education and research. So being the best is not just about a campaign or a program or current metrics or measures associated with how we rank relative to the other academic medical centers. It's about being recognized for what we come here to do, leading and making a difference. So the other reason that I wanted all of us on the stage is I wanted you to hear from Ms. Sagro and Dr. Jacobs relative to best care, being the best,
how they're thinking about this and what they're communicating to the parts of the organization that they oversee. So let me start with Ms. Hager. You all know that she's been with us for a year and a half.
It's almost 2 years.
Almost 2 years. Time flies. She came to us from the private nonprofit world. And there's been a huge focus on quality of care, patient-centered care, safe care, equitable, efficient, effective care, timeliness of care. They're all the things the Institute of Medicine told us that we need to focus on in that private nonprofit world. And in that world, the people who provide institutional support services are often the ones who are driving, leading, facilitating the efforts to move towards the best possible outcomes as measured by these metrics. So she brings a lot to the table. She's been working closely with our operations folks, Ms. Sollenberg and the health system, Dr. Jacobs. Clearly, if we can't get supplies and pharmaceuticals to our care providers on time, if we don't have a clean and safe environment, facilities that work, we can't be successful. What role does IT play in terms of delivery of care these days? Critical role. What about the people we have? What about recruiting nurses? We're talking about that. We have to be able to attract and retain great people. Our HR consultants and guides are helping us on that front too. So everybody in institutional support, certainly in finance and revenue cycle, are fully engaged. And I just wanted to talk, maybe say a little bit more about your perspective on this.
Everybody hear me? I think institutional support has a tremendous impact on best care. Dr. Callinger just named some of those ways that we can impact. It's not something maybe that you think about first off the top of your head. A lot of what we do, and he alluded to this a little bit from the private nonprofit world, is help out with actually just the business part of getting some things done. How do we organize? How do we actually set some goals and some metrics so that we can really focus in and maybe improve some of those areas that Donna outlined a little bit earlier. I've asked a couple of folks, I didn't plan them, I'll tell you that, but I asked a couple of folks if they would just stand up real quick and tell us what they thought best care was in their particular area. So I'm going to start with Emily. Emily is our Vice President over Revenue Cycle. She's been here 7 months? About 7 months. So will you just let everybody know what you think Revenue Cycle contributes to the best care initiative?
Okay, I have a couple of things come to mind, but I think primarily, from a revenue cycle perspective, is our impact on the patient experience. Because we're not clinical, sometimes folks forget how often and how much we have contact with the patient. Sometimes it's even prior to them coming in for services, as we're making outbound phone calls to them. All the way through to the very end, we're sending statements out, and really we're trying to resolve those accounts to a zero balance. So there's a long range of time that we're impacting, we're contacting the patient and impacting the patient experience. Secondly, we have coding within our shop, and it's very important that, especially in the inpatient arena, even in regards to these metrics here, that we're coding our services accurately. We certainly want to capture all information within the record, code everything that's documented accurately, so that we're accurately reflecting the severity and the risk of our patients. And finally, certainly we want to optimize our net revenue so that we are contributing to the financial health of the organization.
Thank you. Everyone more? Mike Schreiner is the Vice President for Business Operations and Facilities. Everybody, Mike, right?
That's a good thing.
Yeah, I hope.
Okay. Well, so we have a lot of visible things we do in my area. And it's wonderful to see the recognition for the environmental services teams that support the campus. Healthcare represents about a third of our physical facilities. That's about 2.5 million square feet of healthcare facilities that we watch over. Thinking about the crews that are out there every day taking care of the environment, what you see when you walk down the hallway, but also the infrastructure that's serving that. So the fact that the lights came on this morning, when you flip that switch, or that the heating and cooling is working appropriately, and all of the systems that it takes behind the scenes to make sure that environment is appropriate. And then, of course, the supply side, making sure that the right supplies are in the operating room, or interventional radiology, or in the nursing unit. We have staff out there every day and making sure those things are happening. So we have this sort of direct connection to patient satisfaction and to the environment that is important, obviously to the patient, but we want to make sure that all of our employees see the impact they can have on that.
Thank you. So many different ways, obviously, information technology, human resources, Ron working, his team working with David Marshall, just had a really successful hiring event. I think we made offers to 50 nurses, is that right? 57
Congratulations,
nurses.
thank you.
So thank you, David, Ron, and your teams for really getting out there and making sure that we have the right people to take care of our patients. So a whole cadre of things that go into institutional support that we don't certainly document in a file or take direct care of a patient, but we're right there beside those caregivers doing everything we can to make that patient experience as best as it can be.
Very good, thank you. Well, Dr. Jacobs, you have a huge role. You have the clinical faculty, the providers, delivering healthcare services, a lot of the systems that really support care, in many cases the metrics that track performance come under your purview and oversight. So how are you thinking about this? What are you saying to the people in the academic enterprise about the effort?
Well, that's a great question, and all questions are good, of course. As I was thinking about our meeting today, I remember that Ms. Sonnenberger, I think, framed it perfectly when she said, when she asked the question, well, why wouldn't we want best care? I mean, isn't that what we want for ourselves and for our loved ones? That was sort of a very nice framing. So what can the academic enterprise do? There are many things, but maybe I summarize it in a couple ways. I mean, we have worked hard since I've been here 4 years in October to tighten the binds across the whole institution, including partnering with our colleagues in the health system. I think there's great evidence of that work, you referenced some of it, where people are now coming together in a way that I've not seen before. It wasn't bad, actually pretty darn good when I arrived, but people are getting the message. So, for the academic enterprise, one part of it is, well, how can we partner more effectively around all the things we've identified as opportunities? And we have great people. I think the faculty and staff members are engaged. So when I meet with them, I talk about best care, I ask them to help me in one of two ways. Tell me what I can do more of, or tell me what I can do less of. And that may sound sort of cavalier, but it really is about being laser focused on the things that Ms. Sonnenberger has identified, so we can ask that question and move quickly. And we have to be nimble and agile, as you also referenced, because our people are so good, Dr. Kelder. I believe that they understand what needs to be done to the point of impact now. How to get that done is another exercise in communication, another exercise in drawing a distinction between command and control and cultivate and coordinate. But I think we're ready for it. From my colleague Ms. Sabro, there are many things she's already referenced that are pretty important. But one piece that I think is particularly important is translating data to information. So we need information in real time that allows us to be able to see the impact of the actions we're taking. And I make that distinction between data and information intentionally, right? So we can actually have actionable items. So among all the many things that are happening in shared services, that's critically important. Then lastly, I'd say, when you think about best care and you think about Ms. Sonnenberger's framing question, well, and as you said, Dr. Kelder, it has ties into everything we do in the academic enterprise. So let's frame that another question. Don't we want to train our trainees about best care? Don't we want to prepare them for what the world looks like? Absolutely. It's an obligation, it's part of academic duty. They will see us and work with us to move towards that top right-hand corner of excellence. I think that's very exciting. It makes me feel like that's one of the reasons why we're here. On the academic/research side, there are also very important parallels. And I think of it as so once Ms. Sabro and Ms. Stollenberger helped us draw that distinction between data and information, where the academic enterprise can help in particular is about asking the questions. Now that we have the data sources that now are information sources, we know we have a pretty good idea of the things that we can improve. We'll be later focused on those. Let's say readmission rates, sepsis rates. But I think when we talk about, I call it capital P population health, saying that there's another element to that. The ability to ask questions of the data that we have, which will now give us answers, is an important contribution for the academic enterprise, where we can help. Preventive medicine, community health is the one that comes to mind. How do we design ourselves? How do we design our delivery systems? Health services research. We have great expertise that can tie in very much to that. Our clinical transformational science report talks about bioinformatics and converting data. If you look at those things that directly relate to patient care, a couple things come to mind. We have world-class services in many areas. You gave an example of some of the expertise in OBGYN, but we're top 3 at least as regards infectious disease and immunology. How can we translate that? It doesn't necessarily translate everywhere. How can we ask that person about the expertise that we have? It could be device, product, vaccine development that can also eventually get us to the other elements of best care besides the things that are in business. When you think about pain or pain management, which is one of the things that was on this slide, we have world-class expertise here in just those very areas. Now, not everything we're talking about will come to fruition in year one, but when we talk about how do you motivate our investigators, I think it's the same line. There are very many ties to best care as that top right-hand corner that inspires to go.
Very good. Thank you very much. So, I think that you hear today from our EVPs that this is an institution-wide effort to engage the data that's describing what we do, every aspect of what we do every day, and demonstrate our commitment to being the best. That's all good. Hopefully the other thing that you've seen and heard today, much of what's required doesn't require a huge investment in terms of infrastructure or new tools. This is really about behavior, changing the ways that we communicate, we work together, particularly how we work together more effectively to deliver outcomes that are better, deliver service that qualifies, as Dr. Jacobs said, in that upper right-hand quadrant that represents the very best. I know a number of you in this room are very much engaged in those efforts already. A number of you I recognize are in designated leadership positions and working hard to make this happen. I want to particularly call out the role of our clinical chairs in medical school who have really engaged this and are working to engage the faculty. I see Dr. Doug Tyler from surgery, Dr. Randy Urban here from internal medicine, Dr. Mike Papasato from pathology. If I missed anybody else, but I just want to say thank you to you all for helping us engage this data and understanding what it means, what it will take to be represented as the best. So let us stop there. I think we have maybe a few minutes for questions. Any questions from the audience? Anybody have a question or a comment? What about those from the Employee Advisory Council?
Hi, my name is Jill Bryant Boba. I'm the Almeida Advisory Council, and I am representing hospital clinics. One of the questions we received is it realistic to think that we can move so far so fast? And what happens if we don't?
Great questions. You want to respond to that?
You can do the what happens if this is not going to be easy. Jill's got a great question, whoever submitted it, or maybe it was multiple people, because it's going to take laser-like focus. And it means that some of the things that we might want to do, we may have to hold for a little bit because it's going to detract from that focus. I think that when you looked at the example I gave of OBGYN with Dr. Hankins and Dr. Sadi and their whole team, really, they moved the needle quickly. So I think it's, once we got the data in their hands, they went after it and they basically changed the performance in 6 months. So it's achievable. It's going to take focus, it's going to take commitment, it's going to take accountability, but we can do this. And from my point of view, we have to do it. We want our patients to receive the very, very best care. If it doesn't happen, what I want to see is we may not make it to that exact 20, but have we moved the needle in significant ways toward that? I think that if we were moving up into that top quartile, which was top 25, we would be in exactly where we wanted in that trajectory. Dr. Callender, do you want to talk about what happens if we don't? No, chair here.
You know, the time frame is certainly challenging, but it's still, I think we can move along significantly. What's more important? What are you doing today that's more important? Delivering the highest quality patient care and being recognized as doing that. And so we have to keep it front and center, and sometimes it's hard for us. Think about the list of things on your desk that you're supposed to do today. So it's going to involve us across the institution, reordering our lists, sometimes doing things for the convenience of others who are important members of the team, as opposed to doing it at a time that's most convenient for us individually. That's what teamwork looks like. It's hard to do, particularly in an operating environment like we have, but it's absolutely critical. Now look at that list. We're sort of right there in the middle. That means 50 some odd organizations have already figured out how to do this. Are they smarter than we are? No. Are they any more capable than we are? Absolutely not. And we can tell you multiple stories about organizations that have left off 40 to 50 positions in a single year. So we know it's doable. Is it going to be challenging? Absolutely. But we're the ones who set the standard to be the best. I think we need to change our priorities, keep that laser-like focus that each of these three have described, and move forward to get it our best shot. What's going to happen long-term if we don't make it? This entire place is going to look radically different. That's not what we want. We want that 125-year legacy of great service to the people of Texas, people around the nation, people around the world to continue. You know the reason it's happened before, at least from my perspective? Because the people who were sitting in these chairs responded to the challenges just like this one. To change, to do it better, to do it the best. That's what we're going to do too. So let's stop right there. We're out of time. Enjoy your lunch if you have a lunch ticket.